It is a great pleasure to be here. This is my first conference with you, so I'm very appreciative to be able to be here and share what I do with you. And, you know, if I could click on the presentation, I will open it and we can start. I'm sorry. All right.
Oh,
and hopefully our projector should be on?
I think it's off.
Okay.
How do you turn it on?
I'm sorry. I'm even having trouble just double clicking. I don't know what the deal is here.
I can guess with you. That looks like a power button. And it turned green, so it's a good sign. Just wait, probably just wait. It takes a while.
Okay, sorry. It's starting to load.
Coming.
Sorry.
I hear it. Yeah.
And in your programs, both my name and Naina Patel, who's my colleague at the university, our names are listed for both, but I'm doing this talk on thyroid nodules and ultrasound selection criteria. And then Naina is going to follow me, I believe, also in this room and talk about pre- and post-operative sonographic assessment of the nodes. So that's how we're breaking that information down. Okay, and I don't know if there is there's a way to turn down the lights a bit. Thank you, thank you. So I think it is better if you could save your questions towards the end. I will leave time for that. But if anyone has a burning question as I go, feel free to interrupt me, right? We can be flexible. I am an assistant professor of radiology at the University of Colorado. I'm also the director of ultrasound there. My goal with this talk is to inform you about the general indications for neck ultrasound. One of my main goals is to demystify our language as radiologists. A lot of you, like in our hospital, have access to your sonographic reports. So I want you to understand what we are saying in addition to your doctors. I want to go over some basic thyroid anatomy, discuss a bit about some diffuse thyroid conditions, and then the meat of my talk is to focus on evaluation of discrete thyroid nodules. What is the biopsy criteria for benign versus malignant nodules? How do we choose which ones to biopsy? Okay. So generally, some of you may have experienced this. Indications for neck ultrasound would include any palpable enlargement, if you have abnormal hormone levels, if there is swelling in the neck or asymmetry of the neck, again, relating to palpable abnormalities that your doctor may feel in a physical exam. Redness or tenderness, if there are swallowing difficulties, often that can be attributed to thyroid conditions, therefore an ultrasound will be indicated as well. A lot of patients come to us because thyroid nodule is an incidental finding on a different imaging study. You're getting a chest CT for some reason, you had a carotid ultrasound, so you know, thyroid nodules are pretty prevalent, so we might find them there and suggest further evaluation with ultrasound to characterize them, or pre or post thyroidectomy evaluation in the setting of cancer, which, as I mentioned, my colleague Naina Patel will be discussing following my session here. So just in general, just with regard to the scanning technique, ideal patient position is with the patient supine with the neck extended somewhat. We might use various means of neck rotation. Okay. People may or may not be able to do that as readily depending on other musculoskeletal conditions, so we'll work with what you can do, but ideally supine with neck somewhat in hyperextension. We use a linear transducer, which is a high-frequency transducer, which gives us good detail of the thyroid, which is a very superficial structure. We have various ways to optimize the image, and we evaluate in 3 scanning planes. So I wanted you to be familiar with this because there's just different standards throughout the community. You might have different experiences with regard to what your radiologists are reporting. There are, in fact, practice guidelines that have been issued by the American Institute of Ultrasound and Medicine, which is one of the governing bodies in ultrasound that we followed, and one of our accrediting institutions at our hospital. Typically, within your report, the location, size, number, and 3-dimensional measurements of nodules should be included. We should discuss whether the thyroid abnormality is a localized or diffuse abnormality, and we should discuss the sonographic features, including the echogenicity, which I will discuss what those are, the composition, the margins, if there is any calcification, and any other relevant sonographic patterns, okay? The neck ultrasound should also always typically include presence and size of abnormal lateral neck nodes. So we sometimes will be asked to evaluate outside ultrasounds. I always consider them absolutely suboptimal if we don't have evaluation of the lateral neck nodes. It's essential, okay? So if in your community you're not getting that, that should always be included, okay? That is a practice guideline. So in terms of demystifying our language, this is important, I think, for you to understand, but especially important for our referral clinicians to understand, which could be family practitioners, endocrinologists, surgeons. We all want to make sure that we communicate effectively and that our language is clear. So when we're referring to echogenicity, we're talking about generally these terms. Anechoic means absence of any echoes, so it typically looks black on ultrasound. It is typically a fluid-filled structure. Isoechoic means that it has echosimilarity to the thyroid itself. If it is hyperechoic, it's typically brighter than the background thyroid. Hypoechoic, it is typically darker than the background thyroid gland. And if it's markedly hypoechoic, that's typically in reference to the musculature. We can also talk about the composition. From being something that is completely cystic, 100%, or fluid-filled, to being completely solid, 100%, and then different patterns in between, predominantly cystic, mixed, or predominantly solid. So that's language that we may use, and this is the criteria that we use for that descriptor. In terms of other findings that you may see, and so I know there's a lot of words, but I promise I will show you pictures. I am a radiologist. I will show you pictures. Microcalcifications refers to punctate hyperechoic foci less than 1 millimeters. They typically do not have an acoustic shadow, okay? This is highlighted in a different color because, as you all know, this is the pathognomonic bad buzzword, okay? We see microcalcifications, typically, and if we use that word, we have a suspicion that there is a cancer, okay? Macrocalcifications typically are hyperechoic foci that are larger than a millimeter, but as we know, that can be hard to discern, or microcalcifications may coalesce. So, basically, any calcification is potentially a red flag, but you have to evaluate it in the context of the whole of the nodule as well. If you ever hear the term halo, that means that there's kind of a hypoechoic rim, as if you took a pencil line around the outline of the nodule. It can be thin or uniform, thick, absent, or incomplete. We will use comet tail reverberation artifact. I guess you have to be an astronomer to appreciate this, but if you think about kind of a shooting star and the tail that is typically going behind it, there's a little artifact that we can see associated with tiny echogenic foci, and that's called a comet tail reverberation artifact, and that's typically indicative of the presence of colloid. So if we see that, that's actually a very reassuring sign. But differentiating those echogenic foci that might be colloid without a comet tail artifact versus microcalcifications can be hard, okay, because they both can be punctate. So here are, sorry, I don't actually think I have a pointer, sorry. But up in this top corner here, anechoic, looks completely black, okay, absence of echoes. Isoechoic, the nodule in the corner there, has echosimilarity to the background thyroid. Hyperechoic, this nodule here, it is brighter than the background thyroid. And then hypoechoic, you can see it is much darker here than the background thyroid gland here. Basics of anatomy, there are right and left lobes that are located anterior lateral to the trachea and the esophagus. The lobes are connected in the midline by the isthmus, and the size, length, AP diameter, and isthmus have those dimensions as below. So this is a typical picture, right lobe here, sorry, I wish I had a pointer, sorry. Left lobe on this side, and the bridge of tissue in between is the isthmus. There are also, this is Nina Patel, your savior, thanks Nina. Sorry, thank you Nina. So neck muscles, we can also see the neck muscles, and those are important landmarks with regard to compartmentalization of the neck, which Nina will discuss with you later. But we can see, so here's kind of a panoramic view. Here's the right lobe. Oh, Nina might have killed it. Huh? All right. I see the laser, but I don't see the laser. All right. So here's a panoramic view. Anteriorly, up above the echogenic thyroid is The anterior strap muscles, the sternocleidomastoid is out here. The longus colloid posterior muscles are here. Thank you. Sorry. Neck vessels, the major ones that we take into account, again, for compartmentalization of the neck and that we can readily see, are the carotid arteries on either side. They look very round, and the jugular vein as well. And that helps, that's primarily the discriminating line between medial versus lateral neck, which is important in terms of surgical planning and optimization. So let's talk a bit about some diffuse thyroid conditions. These are important because this can confound our ability to discern discrete nodules. So it's important for us to recognize them. There are several conditions that may result in hyperthyroidism or hypothyroidism, as well as cases of thyroiditis. So hyperthyroidism, kind of the typical example, would include Graves' disease. A lot of you will be familiar with that. There's an overproduction of thyroid hormone. Various causes, including an autonomously functioning nodule versus a pituitary tumor. They obviously have symptoms of increased thyroid hormone production, tremors, sweating, palpitations. Okay. Sonographically in Graves', the thyroid can appear enlarged and heterogeneous. It may be diffusely hypervascular. Various treatment modalities, including iodine, medication, or surgery, depending on the situation. So here's kind of a typical example of enlargement of the right lobe. And if you keep in mind those previous normal pictures I showed you with regard to anatomy, see it looks a little different by grayscale as well. So enlargement of the right lobe, enlargement of the left lobe. When we put on color flow, you can see there's a lot of vascularity associated with that lobe. No, not necessarily any discrete nodules, but on this background you can see it can be harder to discern those nodules. Hypothyroidism, in contrast, is undersecretion of hormone production. Various causes, including low intake of iodine, thyroid hormone failure, pituitary disease. Symptoms include weight gain, cold intolerance, hair loss, among other symptoms. The sonographic appearance can vary. The treatment is typically medication. Now, in terms of us determining just by looking at an ultrasound whether someone is hyper or hypothyroid, we can't always discern that. We can't. We need the clinical information to help us, okay? There's not any specific imaging findings that will tell us that. Thyroiditis, you can have acute, subacute, or chronic versions. Hashimoto's is a typical example of chronic lymphocytic infiltration. Acute causes are very rare. They're typically caused by a bacterial infection. You can have a painful, firm, enlarged thyroid. You may even see an abscess. Okay. Patients will have neck swelling, fever, and pain. For subacute cases, de Quervain's disease, it typically follows a viral syndrome. Again, you can get a painful, enlarged thyroid, and the thyroid can also appear diffusely hypoechoic. So here's an area where on this side of the screen you have very dark appearing portion of the lobe. Over here is more so the normal echo texture. Variable blood flow with more so in the portion that is darker. This was a subacute thyroiditis. Okay. Chronic thyroiditis, the typical example is Hashimoto's, and a lot of you might have a background of Hashimoto's. It is an autoimmune disease, often resulting in hypothyroidism. They are at increased risk for papillary thyroid cancer. The symptoms are typical of hypothyroidism. The sonographic appearance, Hashimoto's has a very classic appearance. So most of the time when we get an ultrasound, on our screen that has this appearance, we know, we're like, oh, this is a Hashi's gland. It has a very classic appearance. Typically the gland is enlarged, hypoechoic. There's a coarsened echogenic, coarsened echo pattern. Typically they have multiple hypoechoic micronodules, usually between 1 and 6 millimeters. Echogenic fibrous septa and bands are common. Because of the fibrous bands and the micronodules, you can get what's called pseudonodules. You're not certain if they're really discrete nodules or just related to background heterogeneity of the gland. So if you get reports where we use the term pseudonodule, that's where we can't tell if it's really a discrete finding or not, or if it's just because the background gland is so heterogeneous. It's a false positive, if you will. Benign and malignant nodules may coexist in a gland with background Hashimoto's nodules. Hashimoto's thyroiditis, they also do typically have associated lymphadenopathy. Typically the nodes are reactive, okay, so they're typically enlarged, but they will usually maintain the normal morphology, which you'll see when Dr. Patel gives her talk is in contrast to nodes that we suspect might be involved in a malignant fashion, okay. In the late stages of the game, you get what we typically term a burned out thyroid, so the thyroid becomes overall small and atrophic. Treatment is typically with medication. So here's a classic Hashimoto's thyroiditis. Okay, so looks very, very busy. You can see the airway here in the middle, and you can see each lobe how heterogeneous it is. There's dark areas, there's light areas, there's some little white fibrous strands going through, which are those fibrosepta. You can imagine how hard it is kind of looking at that gland to determine which is a real nodule, which isn't, okay? Typically, they may have increased blood flow. Here's another example, a different patient, okay? But it looks similar to the last case, but again, diffuse heterogeneity throughout, okay? And again, lots of blood flow. Here's an example of someone who has kind of end stage or late stage Hashimoto's, where we would typically term it burned out. Initially, we had studies that looked more like the ones that I just showed you, and now it is a very small atrophic gland. You know, sometimes it's even hard to us to discern the lobes to measure them even. Okay, and then here's a case where you can see several areas where, okay, is this a nodule? Is that a nodule? Is that a nodule? You know, it's hard to tell. Typically, the rule with ultrasound is if you can, for something to be real, it should persist in both views. So if you look at it in the transverse plane and you turn on it in the longitudinal plane, you should still be able to draw a line around those borders. And if you can't, could be a fake out. You know, typically in that situation when we're not sure if we're dealing with a real nodule or a pseudo nodule, we would recommend the short-term imaging follow-up, okay, and see if there's been a change. So on to focal thyroid nodules, okay. So again, this is, most of the time, we are dealing with focal thyroid nodules and with underlying suspicion of cancer or non-cancerous. Here are the features that we look at sonographically to help us determine. So this is evidence-based. There have been lots of papers, lots of research regarding the features of thyroid nodules. So benign nodules tend to be wider than tall. They, cystic or predominantly cystic nodules are typically benign. The echogenicity can vary. They can be brighter than background thyroid, have echosimilarity, or be darker. Okay. Typically, if they have a halo, the halo is thin. Okay. They typically will have well-defined margins. If there are calcifications, they tend to be the macro calcifications, or what we will also term coarse calcifications, as opposed to the micro calcifications. If there is flow tends to be peripheral. In contrast, malignant nodules are typically taller than wide. They are more often than not hypoechoic, so darker than the background thyroid, either hypoechoic or markedly hypoechoic. If they have a halo, it tends to be a thick or incomplete halo. Halo may also be absent. The margin is not typically well defined. It might be spiculated or irregular. Presence of microcalcifications is typically pathognomonic, and if they have flow, it would typically be internal or central flow. Now, not every single benign or malignant nodule will have all of these features, but we look at it as a whole, you know, and you know, the more that you tally on the malignant side, the more likely we are to say, hey, we're suspicious, we should needle this, we should definitively characterize this nodule, okay? This is a chart that is up in all of our reading rooms. This is actually a chart from 2005, written by Bill Charbonneau and Carl Redding, and it's based upon their experience at the Mayo Clinic. I love this chart because it is pictures. I think in pictures, I think in patterns, I think a lot of radiologists do. And this is a chart that just kind of lays things out very nicely. I'm going to go through these and kind of explain them. But if you look on this side, worrisome for malignancy, FNA, you see features that I just talked about. Hypoechoic, microcalcifications, some irregular margins. It's not a nice smooth line around those nodules. For the indeterminate category, in between, they might have a smooth margin. They're predominantly solid, or they might have some mural projections within a largely cystic nodule. So again, kind of a gray zone. And then over here, for the almost certainly benign category, majority cystic nodules with kind of a colloid or spongiform appearance, which I will explain, or in the setting of a multinodular gland or a Hashimoto's background where you're not certain that there's a discrete nodule, but you have kind of confluent margins of similar pairing nodules. This is a chart also from 2005, and I don't expect you to read this small print. I just wanted to show you what was in our reading room, okay? So, in addition to some other things, but we have this chart, which is a great pictorial guide. Sorry, I didn't mean to go back that far. Okay, so we have this chart, which is a great pictorial guide because we're dealing with pictures, we're looking at images every day. And then we have this chart, which is the verbiage related to this pictorial guide, okay? Basically, this is a comparison of two criteria, and there are multiple criteria that people have set forth regarding when and when not to do thyroid FNA. These are the two that are kind of predominant at our institution, but you know, we give preference to the ATA because even though we're radiologists, the Society of Radiologists of Ultrasound also set forth criteria, but the ATA defines more precise criteria or covers for more patient scenarios, if you will. Has a little bit lower threshold in terms of biopsy. So this is just a comparison of that ATA and SRU. We're looking, ATA takes into the patient history, whereas that was not addressed with SRU. For microcalcifications, which is here, you know, they both talked about you would do it if you had presence of microcalcifications and nodules that were at least 1 centimeter. So for the most part, these criteria are similar. But this is what we use, and I'll go through this again. And here's the latest version of the ATA, which I don't believe is out yet. Sorry, it's projecting rather dark on here. And I got this from my colleague, Dr. Brian Haugen, whom many of you probably know. He's the chief of endocrinology, really awesome clinician and educator. But this is the latest that will be out if you haven't seen it. And what I really like about this is, as opposed to their last statement, which basically I kind of showed you a synopsis of that just now in comparison with the SRU, this one includes pictures. So it's more near and dear to my heart and just easier to interpret. So when we're talking about nodules with high suspicion, we're typically looking at solid nodules, so that's that whole first row. So for nodules with high suspicion meaning greater than 90% chance that this is likely a cancer, we have some features. They may have solid nodules. They do set a criteria of at least 1 centimeter. They are typically hypoechoic and have microcalcifications. For moderate suspicion nodules, moderate being about a 10 to 20% chance of malignancy, they may be solid and hypoechoic without microcalcifications. Mild suspicion nodules, between 5 and 10% chance of malignancy, they tend to be iso or hyperechoic, okay? They may be solid or partially cystic, okay? Low suspicion are these nodules that are majority cystic or cystic with features of spongiform or colloid nodules, okay? And the benign nodules, which it's rare to have true complete thyroid cysts, but completely anechoic. So the risk of disease is listed on the side from high to low. So the risk of malignancy goes up, okay, with more solid features, hypoechoic nodules, microcalcification. So when we're looking at nodules, we kind of do a tally of these features and decide which ones merit biopsy based upon the sonographic criteria. So this is just the verbiage that accompanies the pictorial chart, which is the latest recommendations per the ATA that I just showed you. So solid nodules or partially cystic nodule with one or more of the following features: irregular margins. This is the top row, second box. Irregular margins, microcalcifications, or taller than wide shape have a greater than 70 to 90% chance of being malignant, and we would consider biopsy if they're at least 1 centimeter or larger. Okay. And I would say at our institution, you know, we biopsy all of those pretty much that meet that criteria. For intermediate suspicion, it may be a hypoechoic nodule, typically without microcalcification. 10 to 20% risk of malignancy greater than 1 centimeter would also be our threshold. Okay, so again, for lower suspicion, we would increase the size threshold to 1.5 centimeters for isoechoic or hyperechoic nodules without microcalcifications or without any evidence of extrathyroidal extension. And for very low suspicion would be our spongiform or cystic nodules. For some, if they get large enough, at least 2 centimeters, then we might biopsy at that time. And again, having said this, the nodules don't read the books either, right? The nodules don't care what kind of charts we've put together. So if there are circumstances that warrant that we might need to do a biopsy outside of this criteria, sometimes we're in a position to do that too. So, we have to take individual scenarios into individual risk factors, individual appearances into account as well. Just a brief, I showed you very briefly and you guys have seen the linear transducer that is typically used for diagnostic scanning. This is what we use at the University of Colorado when we do our biopsies. It's a smaller probe. It's a curved 8 megahertz, so it gives you a little bit more depth, but we like it a lot because it gives us more maneuverability on the neck. So that's just a difference in our practice. At our practice, we also do use a sterile preparation. We always give folks lidocaine. We use 25 gauge needles, and we typically do 3 passes. So that's our general approach. But I know a lot in the community, they also use the linear transducer for biopsies too. That's just not what we learned at our institution, so we do it a little differently. Works very well for us. So. Benign focal thyroid pathology would include colloid nodules, adenomas, goiters, and cysts. So colloid nodules include, and you'll see this term in your reports, we use it freely if we're confident that we're dealing with a colloid nodule or suspicion of a colloid nodule. Colloid is a product of the thyroid that consists of thyroglobulin and serves as a storage reservoir for thyroid hormones. You can find colloid nodules within the thyroid gland in the terms of colloid crystals and colloid cysts. They typically will appear anechoic. Sometimes they appear complex, and they have that comet tail artifact that I referred to earlier that I will show you. Overwhelmingly, if you recall those charts, they are benign. We try not to biopsy colloid nodules if we're certain imaging-wise that they are colloid nodules, just because we typically don't need to. So the other term that you might hear is spongiform or honeycomb. So when honeycomb is referring to like a beehive. So think about how a beehive looks where you have these cystic spaces separated by thin septation. So it's a descriptive term for the appearance of that nodule. And if you use your imagination, you see how that's a little bit like a honeycomb, the soft tissue septi and the cystic spaces. Okay, so and we can have these linear echogenic foci that can be present due to the back wall interfaces of the internal cystic component, which is identified here. And you can also see them because of the colloid, which will project as a comet tail artifact. Can you see that in the middle there? The punctate echogenicity, and then the white line going directly behind it. Okay, so microcalcifications don't do that. Microcalcifications don't shadow either. And when I say shadow, it's typically a dark line behind a calcification, okay? But microcalcifications will not have this comet tail artifact, which is this accentuated white line behind a punctate echogenic focus. So when we see that in the context of a nodule, which has overall spongiform or honeycomb morphology, we can be assured that this is a nodule with benign morphology, okay? So you will see us talk about those, and we won't recommend biopsies for those that fit that imaging pattern, okay? Here's another example of a colloid nodule that looks more completely cystic, but again, you see that echogenic focus with that white comet tail reverberation artifact behind it, okay? And here's another one that looks a little bit more complex, just in terms of some of the soft tissue is a little bit thicker, but it is still predominantly cystic. We also have those echogenic foci. We have at least 3 of them with that comet tail artifact, okay? So adenomas is another term that we'll use. Is typically is a non-cancerous overgrowth of normal tissue. They can be single or multiple. Typically, folks will have normal labs unless they're functioning. The sonographic appearance can vary a bit, but it typically is pretty focal with smooth borders. They may have a halo, that thin hypoechoic rim around their borders. They can have rim calcification, and they can range in size and echogenicity from isoechoic to hyperechoic typically, but they can also be hypoechoic. Patients are usually asymptomatic, so here's just kind of a typical example of what a typical adenomatous type nodule will look like. You can see it is isoechoic to the background thyroid with a thin hypoechoic halo around it. Okay. And there it is again in longitudinal projection, and you also see a couple of other nodules more inferiorly. There's one that looks a little darker, But if you look a little closer, it looks a little more honeycomb, as does this one here, right above there. Okay. A goiter is just a general term referring to general enlargement of the thyroid. People can have neck tightness. They may have difficulty swallowing. Various causes, hereditary causes, or iodine deficiency, amongst others. Medications can also be responsible. It can be associated with Graves' disease. Typically, you can talk about toxic versus non-toxic versions of goiters. Toxic versions, they have nodules that are functioning, and non-toxic, they have nodules that are typically not hormonally functioning. Okay. The sonographic appearance, you typically have a gland that has multiple nodules throughout. They may vary in size and echogenicity. The gland may also be very heterogeneous. And then the treatment and symptoms depend on the size of the nodules, depend on hormone levels. And again, for any individual nodule in this context, we would evaluate it per the biopsy criteria as per the ATA. Okay, so we won't just see a multinodular gland and say, oh, that's a goiter, even though we think there's a general, lower risk of malignancy overall. We have to look at each individual nodule's characteristic and make that determination as to whether or not we need a biopsy. So again, here's kind of a typical example, and you can see we're not even resolving the whole of this. This is a very large thyroid. You can see the right lobe, you can see the left lobe, you can see the isthmus. Again, you get the sense that there are multiple nodules that have a similar appearance, confluent margins. Here's just a big kind of nodule within a very enlarged gland. So this is what we would typically call a goiter. And again, we kind of look at the overall features to determine if we need to do a biopsy in this setting. Cysts, true cysts are uncommon. Cystic appearing lesions are usually degenerating adenomatoid nodules or colloid nodules, and for the most part they display cystic or predominantly cystic characteristics. They might have internal echoes or irregular walls. Alcohol ablation, typically cysts are leave-alone lesions, but sometimes cysts may be large enough to become symptomatic, and then alcohol ablation is a treatment option for recurrent symptomatic cysts. Typically, we don't recommend FNA in these settings either because the sample yield is very low. If you get cystic fluid all by itself, that doesn't help you discern what is the overall nature of the nodule. And typically, when you're dealing with a lot of cystic component in a nodule, if you cause any kind of bleeding, there's just fluid component. So there's nothing to kind of tamponade any bleeding either. So, and again, here's an example of pretty large cyst. This is on the left side, and you can see there's some echoes in it. Might just have some debris. But typically, unless the patient, had recurrent symptoms, this would just be a leave-alone lesion that we would document. So, in terms of malignant pathology, so these are you're all familiar with these categories. So papillary carcinoma, follicular carcinoma, medullary carcinoma, Hürthle cell carcinoma, anaplastic carcinoma, also known as giant cell, lymphoma, and metastases to the thyroid are typically the malignant pathologies that we might see. As you know, papillary is the most common type of thyroid cancer. It is classified, thankfully, as a differentiated thyroid cancer. Multiple subtypes may be seen pathologically, including tall cell variation, follicular variation, a diffuse sclerosing variant. That's not something that we can necessarily discern by sonography, but those are some of the subtypes that may be identified on path at surgery. Patients may be completely asymptomatic or come to evaluation because of a palpable nodule. Thyroid hormones, as you know, may be normal or abnormal. Thankfully, it is, and I keep saying thankfully because it's the most common type. So thankfully, and this doesn't go for everyone, but it is typically slow growing and least aggressive. Having said that, of course, everyone might have different experiences, but that is at least the expected normal pattern, and it typically spreads through the lymphatic system. The sonographic appearance is typical to have one or multiple nodules with irregular borders. They are typically hypoechoic, but may vary. They have microcalcifications. If they have vascularity, it typically is increased and internal or central to the nodule. If papillary can spread through the neck, so you can see abnormal lymph nodes in either the central or the lateral neck compartment, and typically first-line treatment is surgical. But again, these descriptors are in line with the criteria. Think about the ATA criteria. Okay, so the goal is to try to catch most cancers without having to biopsy every single thing. So we want to stratify the risk. Papillary is being the most common, is the one that we're more likely to catch and want to catch. So hypoechoic, solid, microcalcifications. That's why those three features are greater than 70 to 90% chance of malignancy, and those are the ones that we'll biopsy. So these are two different patients, okay, two different examples. In the top example here, you can see the background thyroid, which is lighter gray, and then you see this irregular nodule. Around the top of it, you can kind of draw a nice pencil line or follow it with your finger along the bottom. Can't really do that, okay? Can't really do that. It's more indistinct, a little more irregular. Very hypoechoic versus the background bland. Here's another example where you have diffuse echogenic foci with, here are some with posterior acoustic shadow. Now I told you microcalcifications don't shadow, but you can have lots of microcalcifications that can coalesce that you could in fact get a posterior acoustic shadow. But overall, this is an ill-defined hypoechoic nodule with microcalcifications. You would absolutely biopsy that and be suspicious of PTC. Okay, here are some other examples. Again, this is a hypoechoic, a larger nodule, hypoechoic versus background thyroid. When we look at it with color flow, there's internal, peripheral, there's flow everywhere. Okay, just grayscale features alone, we would biopsy this nodule. The color flow pattern is just kind of the icing on the cake, if you will, in terms of sealing our suspicion. Okay. Again, two other examples of variable appearance of PTC, but again, the dominant features are consistent. Okay, we've got hypoechoic nodules there. You can draw a line around the whole thing, right? You can follow that whole margin. So it doesn't have an irregular margin, but it is hypoechoic versus background thyroid, at least partially. It's a little bit heterogeneous. You see some bright echogenic foci in there. Those are microcalcifications, so that is a PTC, as are those other two examples I showed you. Here's another PTC. Harder to find that margin, less well circumscribed, okay? But again, very dark versus the background thyroid, which is more so normal here, and then these echogenic foci that are typical of microcalcifications. Sorry, just to drill it home. Okay, another example. Okay, so again, you've got a very hypoechoic nodule. Not much blood flow in this one, right? That other one I showed you, tons of blood flow. So the way I think about blood flow, it's kind of my least specific discriminator. I really rely on the grayscale features. I see a nodule that is hypoechoic with microcalcifications. This is a different nodule. Again, a little bit of blood flow, but not very much. A little more cystic components. Charbonneau and Redding from Mayo described this. As you come down from the top of that nodule, you see this kind of really dark line, this refractory shadow, which is thought to be related to a pseudocapsule. In their experience, all nodules that had that kind of margin were malignant. So whenever I see that, that's a buzz for me to pay more attention to overall those features as well. Moving on to follicular carcinoma. It is the second most common. It is also classified as differentiated thyroid cancer. Typically not aggressive, but can metastasize. Spreads through the bloodstream. Typically, the sonographic appearance can be variable, one or multiple nodules. Variable echogenicity, may have calcifications, may have vascularity as well, a thick irregular halo. Treatment is also typically surgical. So again, here's one that was a follicular neoplasm. Has a pretty well circumscribed halo. You can see where those calipers are. Mostly solid, internal cystic component, isoechoic to background thyroid. Moving on to medullary, they tend to be familial. They are classified as an undifferentiated thyroid cancer. They are typically more aggressive. They may be discerned because they do secrete calcitonin. They are likely to metastasize to lymph nodes, and with medullary as well as with papillary, the lymph node metastases often look like the primary lesion in the thyroid. So that's another clue for us. Again, Dr. Patel is going to address the lymph node evaluation. The sonographic appearance, Similar to papillary, it's typically a hypoechoic mass that may contain multiple calcifications. Okay, again, nodal or liver metastases may also be common. Treatment is typically surgery, as well as other management may be pursued. So again, here's a medullary thyroid carcinoma. You see some blood flow. Here's the color pattern image. There's both peripheral and central blood flow. It is more so an isoechoic nodule to background thyroid. You've got some echogenic foci. I think some might have the ring down of colloid, but there's really no cystic component that's visible. So you should be a little suspicious. And then here's that edge on the side, which Charbonneau and Redding described as being typically associated with malignant nodules. So, and this was greater than a centimeter. So, we biopsied this nodule, and this was a medullary. Anaplastic, thankfully, is the least common, although the most aggressive, and unfortunately the most lethal. It is classified as an undifferentiated thyroid cancer. The neck is tender, the mass is typically hard and fixed, rapidly growing. It can invade neck muscles, vessels, and trachea. Typically, the sonographic appearance is a large hypoechoic mass. So again, this I've only seen, I think, one anaplastic in my real life at the university, and it was just a very large hypoechoic mass. You couldn't even discern normal thyroid around it. We have some echogenic foci, but not bad actors. Lymphoma is, we can see in the thyroid, typically is a non-Hodgkin's type. It may also be rapidly growing hypoechoic and kind of a lobular mass. You can also see multiple enlarged lateral neck lymph nodes in that setting. And then the prognosis varies depending on stage. Here's an image of a thyroid on this side where you really don't have a good view of the right lobe. It's kind of ill-defined and a little bit heterogeneous. And then the left neck, zone 4, you see multiple enlarged lymph nodes. Okay, and that turned out to be a primary lymphoma of the thyroid. Metastases to the thyroid are very uncommon. I think I've seen one or two in real life, as I recall. In our institution, I believe the ones I've seen have been, I've seen a melanoma. Typically, they may be from melanoma. Breast and renal also may metastasize to the thyroid. Typically, the patients feel neck fullness or palpable mass. At our institution, the one, as I recall, came to attention because the patient was getting a PET scan for screening for their melanoma, and lesions that light up on PET, thyroid nodules that light up on PET, have as much as of a 40% chance of being malignant. So, sorry, that's the other way that thyroid nodules will come to our attention if people are having PET CTs, because they're following other malignancies. Hot thyroid nodules on PET should be biopsied. Okay, that's how we treat them at our institution. The sonographic appearance of metastases may vary. Can be solid, typically they are solid, homogeneous, hypoechoic, and typically without calcifications. Sorry, I was trying to time it to make sure I have enough. I have lots of time for questions, but which is great, and hopefully I didn't go too fast, and I'm happy to go back to anything, but I hope that you have a better understanding of the radiologist's role and our responsibility in terms of how we evaluate these nodules, how we report these nodules. My goal when I am reporting a neck ultrasound is that I should be descriptive enough that my referral physician or, a very well-educated patient should be able to picture what I'm describing. Okay, so, and I say that because we see a lot of outside reports that I would read, and I'm not trying to be critical of anyone, but neck ultrasound is hard. Neck ultrasound is hard to do. Thyroids get very busy, especially if there are multiple nodules, and I think there's a general intimidation or fear factor in evaluating neck ultrasounds for a lot of radiologists. So I hope to demystify it. I hope that people do get comfortable, do learn about it, so that when you read a report, you can picture in your mind's eye what that nodule looks like. That's my goal when I try to report my studies. I know you all know this, but just to confirm how essential neck ultrasound is to the evaluation of thyroid conditions, both diffuse conditions as well as focal nodules. And I hope you have a better understanding of the sonographic features that we use to guide selection for a discrete nodule biopsy per ATA criteria. And again, this is, radiologists love pictures, love images. So we have these charts that are just up. And again, the patterns are there. Hypoechoic nodule, microcalcifications at least a centimeter. Those should be needled. And not everybody falls within these patterns. And of course, you make decisions on a case-by-case or person-by-person basis, okay? But these are the general guidelines that we follow. And I think we are successful in catching majority of disease this way. So thank you very much for your time. Okay.
What time is it?
Sorry, it is 1:45. I think I'm supposed to go to 12:05.
I don't think we have enough time for questions right now, but we have another, Dr. Patel is also here with us.
Well, I think she's actually like 12:15 to
Yes, I have
something. Yeah, so she's a separate.
Until what time? Oh, I must have a wrong.
She's the next set, yeah. So I'm sorry, it's listed in confusing fashion because we're both.
They're both listed for both.
Right.
Oh, so you're not going to speak at this session?
No.
Okay.
Sorry.
This is mine.
Oh, and that's later? So we do have time.
So yeah, we have. So I'm sorry. I hope I didn't rush through too quickly. I'm trying to be mindful of time, but I'm happy to take questions.
You said you do cases, you do the biopsy. Do you have a pathologist there? Always. Okay, because if you don't have a pathologist, like where I work, I help with some of the thyroid biopsies. They'll do 5 or 6, depending on the physician, but we don't have a pathologist available. So that's why I was wondering, just for my info.
Yeah, so at our institution, prior to, we've always had pathology on site because they prepare the slides as soon as we acquire the samples. We acquire the sample with the needle, we pass it off to the cytotechnologist who is always in the room with us, okay? So they prepare the slides. Several years ago, we had a pathologist who came, who since left our institution, but he's like, hey, we can provide you with real-time feedback, on site while the patient is still there. We routinely used to do 6. Because we never had that interim feedback from the pathologist, because that was the number per our experience and acceptable standard in the community by which you could be assured that for the most part you were getting a great sample. But there'd be cases where patients would leave, we'd have something too bloody or not enough or wish we had something else because they can't really decide. So we've pretty much, with that real-time feedback from pathology on site, we've pretty much, for the most part, not that it doesn't still happen from time to time, but we've eliminated that unknown factor. The pathologist will come down right away and tell us if we've got good sample, if we've got adequate sample, and in most cases our pathologists are astute enough to tell us exactly what they think it is, and for the most part I think I have yet to see them do a 180.
So you've eliminated like the non-diagnostic cases?
Pretty
That's
much for the most
wonderful
part.
for your
Yeah,
patients, yeah.
Exactly. And like I said, we do 3 passes. It turns out 6 is probably an overkill. Statistically speaking, your first couple passes are probably your best passes. The more that you put the needle in, you're causing some microtrauma, you're just going to get more blood. If the pathologist tells us at that 3-point, and sometimes depending, I'm sure NINA does it too. I judge as I go, like, how well did I see it? Was I exactly where I knew I could be? And if I was, probably nothing I can do to alter my technique to optimize what I get. But if I felt like my passes were a little so-so, I might take a fourth one at the moment. But we do maintain the patient in the department. We wait for that real-time feedback. If they tell us that we're good, we've got adequate sample, they might even tell us what they've got, golden, we're done, we finish. Every now and then, they'll say, hey, McKinney, you got blood or you got nothing. I'm like, oh, okay. So I go back and I talk to the patient. I let them know that the pathologist didn't think I had sufficient enough material, or, we don't have quite enough that they think they're gonna be able to be definitive. Are you game for my taking a few more samples? So, and most cases they are. Sometimes their patients are like, I'm done. Okay, then we'll be done and we'll see what the final read is. But yeah, that's a great question. Thank you. We always have pathology on site.
So just to add on that, so average sample is 3. But let's say if you're sampling nodule which is 4 centimeter, or even between 2 to 4 centimeter, we want to make sure we sample different areas.
Right.
So in that case, we may end up taking 4 parts. So we want upper and mid and lower, and we try to sample different areas. Let's say if we do 3 passes and our pathologist says, great, we have adequate sample, and looks, benign. But based on suspicion, ultrasound suspicion, it's like, it could be concerning nodule. We want to make sure that it's actually benign. We will go back and try to sample the area that we are worried about, densification area or hypoechoic area, just to make sure that it's actually truly benign.
Right.
So yes, the average is 3.
Yeah.
You want to talk about the additional passes?
Oh, yeah, sorry. Thank you, Nai. So we're a team at the university, she and I. We're the 2 out of our group that do the second opinions for biopsies and ultrasound-guided FNAs of nodes or nodules. So, so we typically do 3. In the case of multiple nodules, because sometimes there are people, and some of you may be here, that have 3 or 4 nodules, that, we don't necessarily take 3 passes for all of those. That can be hard, even though the procedure is overall kind of fast. It's hard for people to lay there for each and every pass, especially if we have to numb them for different sites. So we might go down to 2, but again, we always get that path feedback as well. And again, if we get, per the Bethesda classification, if we get nodules with atypical cells of uncertain significance, or that they're not going to be able to discern whether it's a follicular neoplasm versus carcinoma, which typically is a surgical diagnosis anyway, but if they know that they're in that gray zone or hurdle cell changes, then we have the option. At our institution, pathology is the gateway as to whether or not we offer that option, but we do have the option at our institution to offer the affirmative molecular testing. So we get that information at that halfway point, and we'll know whether or not that is appropriate to offer to the patient as well. Great question. Yes?
Should a patient be looking for a treatment center where a radiologist does the ultrasound rather than one where the ultrasound is outsourced to a third party?
That is a good question. We are, so at our, and I'm sure I hope I'm answering this correctly. We typically have sonographers. Okay, so all of our sonographers, if we need to go in and do real-time evaluation, if we're available to do that, then we do. For the most part, it's sonographers that are doing it. But you want someone who has familiarity and expertise with neck ultrasound. You do. Just in my experience, especially looking at some outside cases, there's a lot of variability. And as I mentioned, I think that frankly there's a lot of discomfort with thyroid nodules, just because the criteria seems immense. It seems immense. If you've been doing it 8 years or so, it becomes familiar and it's easier to keep up with those changes. But the criteria is very specific. There's a lot of features. There's a lot of patterns. There can be some overlap. So I'd say, if you see a report that has language that is unclear, or the radiologist, the recommendation is they don't know what to recommend, or whether follow-up or biopsy, or you're just uncomfortable, I'd say, yeah. I mean, as a patient, I would seek a second opinion for my neck ultrasound, because I think it is a difficult area in which to maintain a high standard of excellence. Does that make sense? Sorry, I hope I addressed your question. Yes?
Back close to the beginning of your session, you had a statement there about a benign cystic nodule containing thyroglobulin. I'm confused, I guess, about a benign...
Colloid nodules.
A colloid?
Yeah, so that's colloid nodules.
And that's not benign then?
Yes, they are benign.
Okay, I'm still confused as to why thyroglobulin, which is a marker for thyroid cancer, I thought...
Post-thyroidectomy, it is.
Oh.
Right.
If you have a thyroid, you will see thyroglobulin, right? Because it's, yeah.
Okay.
It's a normal function of the thyroid gland. It's a function of the thyroid.
Normal function.
Okay.
Thyroglobulin. So you could have it. It's a normal. So once the thyroid is removed, then it's abnormal to see thyroglobulin globally, because where is it coming from?
Right, in your serum level. Sorry, thank you. Thank you for asking that. Question?
Thank you. I saw the Hürthle cell listed up there. What are the specifics for Hürthle cell?
In terms of imaging?
Yes. Okay. How do they classify it as Hürthle cell?
It's when they see it on pathology. They
Okay.
actually see cells with that morphology. It's, I'm sorry, I'm forgetting that. I'm blanking on the other word is oxyphilic, yes, sorry.
It's just a different kind of cells.
Right.
Under microscope, they are looking for, and they have like just like sonographic features, they have pathologic features.
Right.
Okay.
Cells look like this time, they put it in the Hürthle cell category. So it is pathologic diagnosis.
Right. So,
Okay.
yeah, there are no specific imaging criteria to
Okay.
identify those.
Is there always a second opinion on the pathology for the diagnosis?
I think typically at our institution, it's reviewed by two.
Okay.
Just for the second opinion, we do have a multidisciplinary conference, which is the where the team of endocrinologists, endocrine surgeons, pathologists, radiologists will meet in one place at a certain time to discuss the cases. So you can ask for second opinion, but it has to go through the right channel, like you have to submit your case and the slides up front. So we can look at it, if there are images, Kristin look at that, pathologists will look at it, and then we get together and say, okay, discuss the case. So yes, there is second opinion.
Okay.
and it has to go through policy.
Okay, thank you.
Good question.
Any other questions?
Yes.
Hi. I have two questions, actually. One is can you talk about how far sonograms have come relative to the management of thyroid cancer? And the second is a little bit on that, too, which is once you have thyroid cancer and you still have, some things that are going on in your neck or your lymph nodes, what is the common procedures to actually continuously assess and evaluate changes that may occur?
Right. So if the second question, if you don't mind, I can address it a little bit, but that's actually the focus of Dr. Patel's talk, which is next. The first question is a great question. I'm sorry I forgot your name. I know I mentioned in the hallway. Charlotte. Okay, sorry. Charlotte. So it is a great question. Ultrasounds have come a long way in terms of what the size of features the size of things that we can resolve, much less discern their features. When I started my residency in 2001, I've been attending for 8 years, going on 9 years now, and ultrasounds in 2001 versus ultrasounds in 2014 are night and day. I'm amazed that, when I look back at some of those early ultrasounds, that we could make decisions, based, good, what we consider at the time. That's the standard, though. Good patient care decisions based upon what we can see. Because in retrospect, we couldn't see much. It was hard to tell if there were microcalcifications. It's hard to tell borders. It's hard to resolve borders of nodules versus the thyroid itself. So, in 2014, I don't know, it's a miracle. It's like taking off the blinders. We can see so much. We can resolve those punctate foci that are just barely 1 millimeter. So we can see that comet tail artifact off of something that is 1 millimeter that can reassure us that, oh, that's just colloid reservoir versus that's a microcalcification, again, in the context of the whole. So you're absolutely right. That's a great question. Ultrasounds have come a long way. We, at our institution, we use Philips IU-22s, which is a high-end ultrasound. We've got 3D capability. We've got all this software. We've got X matrix. So we've got all these amazing toys in our ultrasound as well, including elastography, which is an emerging field to assess for relative stiffness of thyroid nodules versus the background thyroid. It's emerging science. Many of you probably already know, but the theory behind it is that stiffer nodules are more likely to be malignant. That can kind of help you, target which nodules to biopsy or have higher suspicion for versus. So it's just another piece of information, to know whether or not you should biopsy something or you might be safe to leave it alone. But ultrasounds have come a long way. And unfortunately, they're not equal in the community. You know, we don't all have the same machines, you know, and there's the operator-dependent faction of sonographers, right? So at our institution, I'm very blessed. I'm inbred, okay? I've stayed there, and I've not left there for a reason, because I really love it there, and our sonographers are amazing, amazing. I don't have to question their quality. I don't have to question their integrity. They're all very astute young men and women that strive to achieve sonographic and credentialing exams beyond the minimum. So you really want an institution that is vested in your care and that has people that want to do the best work. And not that other people don't, but I think there's just a lack of experience. So sonographer quality is at play, machine quality is at play, radiologist comfort and knowledge with the field in general is all at play. And, you know, as the other gentleman asked, you know, if there's any question, you know, about it, you know, and if you have the option, you know, try to find someone that just has more expertise. You'll get a clearer answer, you'll feel more comfortable with your care. Sorry, question?
Sometimes it's difficult though if you don't, depending on your insurance.
Right, yeah.
Like my insurance won't let me, I can see Dr. Haugen, but I can't have anything done at university. So at the hospital where I work, I made sure that I got the best radiologist and the best person to do the ultrasound. I had a couple people do ultrasounds that were kind of like wham bam, thank you ma'am, that was it. But I found a woman that is so thorough. And so I think that even if you can't go to, because of the insurance, because that's going to be, you know, that's going to be a consideration in anybody's, then you find the best one within the system that you have.
Right, yeah. And like, as I mentioned before, you know, just in terms of standards for ultrasound, you know, any ultrasound that's a great point, and I know everyone doesn't have the freedom to go everywhere, but I think you can be your own advocate and you know, at least make sure, you know, with all your ultrasounds that your lateral neck is getting evaluated. If your lateral neck is not evaluated, that, to me, absolutely insufficient exam. Okay? So ask the sonographer, ask the radiologist if you have the option to, you know, you're looking at my whole neck. You're not just looking at my thyroid. Let's make sure that my whole neck is okay, including the lymph node. Another point?
Yeah, just one more question. Vocal cord cancers or whatever, I mean, I know that's a little bit different, but it kind of all plays in with the neck. They can only be seen through a laryngoscope, not through ultrasound.
No.
Okay.
No. We can see the cords. We can see the cords minimally, but they're typically echogenic. But there's a lot of acoustic shadow, okay? Because of the air that's in the trachea and the cords themselves, and there's calcification of maybe around the cartilage. So it's not an area that we can evaluate with ultrasound. Also, you know, for kind of very large thyroid lesions, thyroid nodules, you know, over 4 centimeters in size. Those are ones that are difficult for us to fully assess by ultrasound. It just kind of defeats our resolution. So if there is a concern for folks that have very large nodules or concern for central disease, that's also another area where ultrasound may fall short. CT or MR would be appropriate in that setting as well.
Thank you.
Thank you.
I just want to say, as a patient, I'm from Canada, from Ontario, and when I started sort of my journey in trying to assess a nodule that was actually found through an MRI, and had it done at a local small hospital in Brockville. And when I went to see a specialist in ENT in Ottawa, I took the films as I was requested on the CD for him to see, and I was curious why he didn't ask to look at them, and he said, oh, it's coming from that hospital. I wouldn't even bother. He said it would be looking through things through foggy glasses for me. And so for me, I've just always been acutely aware of the resources that I have, and when you talk about the equipment, so now being followed at Princess Margaret, and I'm having some symptoms, unfortunately, of late, so they're going to be doing an ultrasound. Feel a lot more secure with that, but I guess as a patient, we're very vulnerable to our area and to the equipment that's there in our hospitals, and not knowing that information.
That is difficult. I don't have a.
Yeah.
I don't have, as the other woman spoke to, you know, it might be confined by regional or insurance purposes. Just in general, and again, if I were in that situation, just ask the best questions that you can. Just try to see if you can recruit the best individuals where you are.
Oh, I just wanted to mention that I live in New York City, and I choose to go to NYU Medical Center for their radiology because it's the largest. They have a big practice, so I know that they have a very good specialized radiologist. And for example, if I go to an ENT and she's affiliated with a different hospital, St. Luke's, not NYU, I have the option to go to NYU because when I called their radiology department, they said, it doesn't matter what hospital the doctor's affiliated with, you can just come here for the radiology. So even if I go to a doctor who's not affiliated with that hospital, now, because of my experience, I choose to only go to NYU for radiology, and I'm very comfortable that I'm getting good service, good equipment, and less rate of errors. So I just wanted to share that with you in case you want to do that too.
Thank you. Thank you for sharing that.
Anybody else?
Thank you so much. I appreciate your coming to my talk. Hopefully you also
Thank
stay
you.
for Dr.
Yes.
Very much a privilege to be here. Thank you very much.